thanks very much, Rebecca, for the introduction. I'm Bella Scantlebury, as Rebecca said, and I am the lead for the Pathways and Culture theme within the Midlands PSRC, and I'm really delighted to be here today to represent the team's work around inequalities in access to respiratory care. And I should say it's really nice to be back in a PSRC, actually, because this is where my academic life started with the Yorkshire team about 10 years ago, so it's really nice to come full circle and be back again. So for those of you who perhaps aren't as familiar with respiratory conditions, they're a major public health challenge and priority area, not only within the UK, but globally. We've seen this reinforced recently within the 10-year plan, where once again they've been identified as a clinical priority area. The reason for this is because they're high cost. So they're high cost to patients and also to society. So some facts and figures. So respiratory disease, it affects about 1 in 5 adults in the UK. It's the 3rd leading cause of death. And as I've said, there's a huge cost associated to our society. So about £11 billion is spent annually in respiratory disease. It's 11 billion. And there's also huge cost to organisations too, in terms of resources. So we've seen a huge exponential increase in the last decade in terms of the number of attendances and admissions related to respiratory medicine. And in general, about 1 in 6 NHS beds tend to be occupied by a respiratory patient. Oh, I've got slide happy here. They're also associated with major health inequalities. And there are a number of drivers towards this. So if we look at what is driving these health inequalities in respiratory medicine, smoking alone is actually the biggest driver of health inequalities in the UK within its own right. But there's also a number that are very specific to respiratory. So if we look at occupational hazards, poor air quality, both inside and outside, these are all things that are driving health inequalities in respiratory medicine. But they're also, what's really interesting is they're modifiable. And this presents us with an opportunity as academics, and we should be excited by this. And we've heard from Ramani about this morning, because if they're modifiable, then we should be able to do something about it. So the work that our PSRC is really excited about doing is trying to do just that, so producing the evidence-based interventions that we can try and then make tangible changes across our society. But the bottom line is that inequalities are not inevitable. They're actually a result of system and policy choices. And as we've heard again this morning, we see that play out in a number of areas. I'd like to focus on geographical disparities, which again, Ramani's stolen a few of my points, but I think we've heard today about north-south being a divide, and we saw this really highlighted a number of years ago through the Levelling Up agenda. When we look at what that means in terms of respiratory disease, we consistently see higher numbers of admissions, attendances, higher death rates, worse patient outcomes for respiratory patients in the north versus the south. But we've actually seen a recent shift in terms of how we talk about geographical disparities, and we've heard a real highlight and a focus being shone on the health of rural coastal populations. Now, this is an area that I have a personal interest. I'm currently leading a HSDR study that's called Elevate, that's trying to improve the way that we organise and deliver care for people in these populations, specifically looking at urgent and emergency care. And one of the questions I always get asked when I talk about that study is, well, what is it about the health in rural coastal towns that's so different? Why is it so different? Why should we be focusing on it? And the reality is that it is very different. The populations themselves are very different. So if you look at what these populations tend to look like, it tends to be older people who are sicker and need more help. Obviously, it's great to live near the coast. I live near the coast, but lots of people tend to do that at retirement age and essentially bring their health problems with them. But the system also struggles in these areas for a number of reasons. So we have recruitment and retention issues for the workforce. We have long travel times for patients to receive care. But also what's really interesting is that actually demand looks very different in these areas too. So if you look at A&E demand, for example, we often focus on winter pressures. Now, for these areas, they see this more acutely in terms of in 2 seasons. So if you think about your typical coastal town, the local population size can treble within the summer months. And that places huge pressure on emergency services to then deal with that. Now, of course, it's not just geographical disparities. We also see disparities in respiratory medicine looking at ethnic and deprivation. So if you think about lung cancer care, the deaths related to lung cancer would be significantly reduced if we all had equitable access to chemotherapy. Now, the second half of this talk is going to focus on highlighting 2 pieces of work that we're leading through the Midlands in terms of respiratory. The first is a policy-focused project, and the second is more of a clinical priority area, clinical priority that's come to us. So many of you will be familiar with the 10-year plan, and many of you will be familiar with the fact that urgent and emergency care is a problem and something that we need to address, and we're not typically very good at doing it. The NHSE launched their recovery plan, which essentially said we need to reduce demand on A&E and we need to change the way that we're designing services to actually make significant changes across the system. As a result of that plan, we saw a number of directives introduced nationally to try and achieve that change, and one of these was acute respiratory infection hubs. So I'll call them ARI going forward. Essentially, these were introduced because there's been data to prove that essentially what we're seeing is a rise in the number of people who are attending A&E because of respiratory problems, but these attendances, they're not translating into admissions. So what that tells us is that actually these patients could be very effectively dealt with in the community and perhaps should be treated there too. We don't need people to be unnecessarily attending A&E if we can help it. And we've seen within the long-term plan recently that there's been a huge talk about shifting care from hospitals to the community, but I think we've all been fairly confused about what that actually means and what some of the interventions could be to achieve that. And ARI Hubs potentially does provide a mechanism for that. It provides a potential solution to that problem. Now, when NHSE said everyone should implement an ARI hub, they essentially said, look, let's focus on a blueprint. Let's not make everyone do it in the same way, which I thought was actually incredibly refreshing, because it allowed places to do some local tailoring to support their local population needs. And actually what we've got in the Midlands is a really excellent opportunity, because we're very lucky. We have Professor Alice Turner, who's pioneering this work in the Midlands through her role in the ICB. And what that presented us with was an opportunity to look at one of the leading areas in the country about what they're doing in terms of implementing an ARI hub, and try to provide the evaluation to inform and to provide that evidence that currently is missing that national directive. So I should say briefly what an ARI hub is. It would probably help everyone imagine it slightly better. So essentially it's like a filtering system, what I said. So this hub sits in the community, and essentially what you can be referred into it in a number of different ways, and that's up to your local area. You can be referred from 111, 999, you can come from your GP, you can walk in. And then essentially, if your condition can be dealt with there and then, that's great. There's diagnostics, you can be dealt with effectively, or you can be pushed back out to the community if that's appropriate, or you can be sent on to the hospital for further testings. Obviously, this model is going to vary nationally, as I've said. So in terms of the Midlands, what we're doing about this is we've designed a mixed methods evaluation, and we're very much in our infancy, so hopefully I can come back and talk about what we found later on. So we're speaking to people involved at national level in terms of ARI hub implementation. We're also speaking to regional service leaders and those involved in working in a hub to find out, is it working? What's the implementation like? What could we be doing better? What could we learn? And then we're also supplementing this with clinical data from across the system. And I really want to highlight this as a really good opportunity to do some excellent work about finding out what the impact of this intervention is, not just on A&E, but across the whole urgent and emergency care system. This systems level approach is what's really exciting for us, actually, to be able to do this. Often when you do this sort of evaluation at national level, that sort of noise gets lost within the data. So we'll be looking at a range of different KPIs from across the system, so not just A&E, also ambulance conveyances, what the impact is on primary care too. And we also have the opportunity, because within the Midlands, there's a bigger sort of push towards integrated respiratory care in particular. And there's a number of sort of parallel initiatives that are being implemented at the same time. So things like diagnostics is being introduced into GPs, and there's also risk stratification for COPD patients in primary care. And again, through this evaluation, we can see, well, is it actually the ARI hub that's making a difference, or is it the combination of all three things that's interesting? So I think the spillover effects is what's really powerful about this project. And so we're supplementing this with economic data as well, because obviously everyone wants to know the numbers and does it make a difference in terms of money. That's normally what ICPs like to know. So we're looking at the clinical cost effectiveness of that intervention, but interestingly also the cost of implementing it, which is often something that's really missed. So what does it cost you to introduce this system into your ICB? As a result of this, what we really feel that this is really powerful in doing is providing that local regional evidence to then inform the national directive, and as well as providing the regional evidence to the ICB as well. So sort of watch this space on that one. The second piece of work is around lung nodules, so a slightly different turn of tacks, and this is being led by Dr. Justin Anger, who's sat over there. I can just see him. And yep, I'm nearly at the end. Essentially, lung cancer is the #1 cause of cancer death in the UK, is also another area that's very, very preventable. So finding ways to identify lung cancer early is essential. We all know if you find cancer early, that's better for everyone typically. One way that you can do that is by following up pulmonary nodules. So these are basically pre-cancerous lumps in your lungs. They may or may not turn into cancer. But the thing with these nodules is that they are often found incidentally. So we have British thoracic guidance that tells us what we should be doing in terms of following up these nodules, but the extent that this guidance is followed is patchy. Performance around this is also patchy, and the impact on patients is, again, patchy. One of the problems with nodules is that this is not something that's coded in the UK medical record, which makes Justin's job super fun. So when we looked at what this does in terms of health inequalities, we had to look at the US evidence. Essentially, what that tells us is that about 40% of nodules are followed up. Your chance of having a nodule followed up is significantly reduced if you are Black or from a deprived area. This is obviously not good enough. So Justin's job has been to try and find out how we can make that pathway better and improve that chance of follow-up for everyone. I'm not going to pretend that I understand what a natural language processing algorithm is, and if you want to find that out, you can go and talk to Justin. But essentially, that's about better identifying pulmonary nodules. He's then led on some qualitative work to understand the pathway within the Midlands for this work as well, to see how can we make that better, what's working well and maybe not so well. A systematic review of interventions to try and improve concordance to guidelines, and then this is all culminating in a grant application that's going in soon to try and essentially create a safety net to make sure that we don't miss these patients going forward. So let's all keep our fingers crossed for that one. So hopefully I've given you a whistle-stop tour through some of the work that we're doing within the ICB. The main thing for us is that we're really passionate about producing regional evidence that can inform national policy directives that are clinical and national policy priority areas. We see that as a real strength of our PSRC, but also as a safety net going forward. Happy to take any questions. Thank you.